That was so good.
I mean, I'm in my house. As an adult, I wanted more games than I was as a child. No Monopoly though, because Monopoly tears friendships apart. Well, at least you guys made true friends at the end now.
Okay, let's go on with the second part. Today's lab is actually pretty short, so it does take long to do if you work in teams like that. Just to make everybody on the same, get everybody on the same page, the pathway of blood through the system here. This is a Frank Netter drawing that I did. You've got the inferior vena cava and the superior vena cava right here, on the right side of the heart. There's a valve that covers the entrance of the inferior vena cava to the right atrium. There's no valve on the superior vena cava because you're mostly upright. If you're upside down, that's why it feels like your head's going to explode, is because there's no valve and blood goes back the other way. The right atrium, when it contracts, it's going to send blood through the tricuspid valve into the right ventricle. It goes out the pulmonary trunk through the two right and left pulmonary arteries. Remember, this is deoxygenated blood into the lungs. It comes back through the pulmonary veins, two on each side, into the left atrium. The left atrium contracts, sending blood through the mitral valve into the left ventricle. The left ventricle contracts, sending blood out the aortic valve into the aorta and the rest of the body. I should mention back over here, there's a pulmonary valve that covers the trunk. Okay? And that's the circulation. If you look at the arterial supply of the heart coming out of the left ventricle, the first two branches off of the ascending aorta are the right and left coronary arteries. And you see them here, the left coronary artery comes off actually behind the aorta. It's in the posterior aspect of the aorta, runs around behind it, between the aorta and the left auricle. The atria, you have the two atria, and then you have these two ear-like appendages of the atria called the auricles. So you'll find the left coronary artery between the aorta and the left aorta. It travels, it's only about 1 inch long, and then it divides into a circumflex that wraps around in the coronary sulcus to supply the backside of the heart. Left coronary continues as the LAD. It's also called the Anterior Interventricular, but clinically everybody knows it as the LAD. The LAD courses inferiorly towards the apex and the anterior interventricular sulcus. Goes around the tip of the heart and continues as the posterior interventricular artery. Now the right, so let's leave it right there. The right coronary comes off the front of the aorta. If you're holding the heart in your hand, the right coronary is going to be right there. Using that technique where you move the fat out, you'll find they're about the size of a pencil. They're pretty large. The first branch, there's a little branch called a nodal branch, gives rise, it supplies the SA node, your pacemaker. I'll talk about that in a minute. Continues in the coronary sinus, gives off a right marginal that supplies the inferior surface of the heart. And then the right coronary continues on the back, and the coronary sinus back here in the back. And the circumflex, the LAD, and the right coronary meet back here somewhere. Now, If the posterior interventricular is made up of branches of the left coronary, you're called left coronary artery dominant. But if the posterior interventricular is made up primarily of the right coronary artery, then you're called right coronary artery dominant. So the illustration, and most people are right coronary artery dominant. There's the right coronary artery, like that. Here's the right marginal. Here's the left. There's the circ. There's the LAD. The posterior interventricular, in most people, comes off the right coronary. This is a big, big deal when you're doing bypass surgery and putting stents in people, which is illustrated here. Now, cardiologists, they name all the little smaller branches, but you see the LAD here. LCX stands for left circumflex. They have these median arteries here you don't have to worry about. There is a left diagonal branch here, just like there's a left marginal branch, just like there's a right marginal branch. It's also called the diagonal off the left coronary. You can see here that it's occluded with atherosclerosis. In this picture right here, it illustrates it best. There's the circumflex. So remember, you're taking a three-dimensional object, making it two. So here's the left coronary. There's the LAD. This will be the circumflex going around the posterior aspect of the heart. 99% of it is constricted. You're still getting blood flow, but it's a trickle. So what you do to these things is you run a wire in there. You can inject this contrast material, by the way. That's how you get the angiogram. But off the end of that catheter, you can take it's a little like a mesh, a little screen wire, expandable screen wire. You push it out the end of the tube, along with a balloon, you blow it up, you put that mesh in place, and now you've got a stent. So this upper panel here shows the blockage right there. They put the stent in, and you've got the return of blood flow distal to the stent. So when you go for your stent placement, they will give you pre and post stent placement angiograms. There you go. There was a study done several years ago on the effectiveness of PAs versus cardiology fellows in doing angiograms, not putting stents in, but just doing the angiograms. It showed that there was no difference in the outcome between the two. Fellowship-trained, fellows in cardiology or PAs. They repeated the study about 15 years later. This was like at Johns Hopkins, exact same outcome. The PAs did the same, the outcome, patient outcome was the same as the PAs and the fellows in doing angiography. So, I don't know any PAs that do angiography of the coronary arteries. There are a lot of PAs that do angiographies and ultrasound-guided things, pretty invasive stuff, but I don't know anybody that actually does angiography. Okay. Think about myocardial infarctions in those blocked arteries. Is you can look on an EKG and you can tell the different types of blockages, whether you're having an inferior MI or lateral wall MI or posterior MI, septal MI, the different parts of the heart. The infarction, the dying cell, the dying heart will show up on an EKG tracing. You'll learn how to read EKGs later on. But if you have a blockage of the LAD, you're going to wind up with an anterior, the septum, or lateral part, or the apex of the heart. If you have a blockage of the right coronary, you're going to have disturbance of rhythm due to that nodal effect. Also the right coronary, if it's an inferior wall MI, it's the right marginal. If it's a posterior wall, it could be the right coronary. The circumflex will also give you an anterior lateral or posterior lateral cell depth on the EKG tracing. So when you look at an EKG, if you go back to the one that I showed you before here, there are 12 different leads. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. There are 12 leads that are looking at the heart from 12 different directions. So what you do when you diagnose it, like an inferior MI, is going to have characteristic changes on leads 2, 3, and AVF. So you can look at an EKG and say, okay, we've got changes in leads V4, V5, V6. That's a lateral wall MI. Where's the lateral wall MI going to occur? That's LAD. That's the LAD. Okay? So you can correlate the EKG with the artery and the tissue destruction. The venous drainage of the heart, some inspired anatomists came up with these names. The great cardiac vein drains the front of the heart. The middle cardiac vein drains the back side of the heart. And the small cardiac vein drains the inferior surface of the heart. These three veins come together in a large vein that's on the posterior surface of the heart called the coronary sinus. That coronary sinus drains directly into the right atrium. You also have smaller veins called anterior cardiac veins that drain the right atrium and the base of the right ventricle. You're not going to find these anterior cardiac veins, but you probably can find the great in the middle pretty easily. These things are very thin-walled and fragile, so when you're trying to scrape that fat off, you're usually going to scrape the vein off as well. But that's not a big issue. You do need to know how it is drained, though, for class. Now, if you look inside the heart, let's look inside. We've opened up the right atrium here. So there's a wall. This is what you're going to do in class. In lab, you're going to make a window and fold that outside open. You're going to open it up. There's a roughened surface on the inside wall here. Those are called pectinate muscles. And then those pectinate muscles stop in a single line. That line is called the crista terminalis. So one part of the wall of the atrium is rough, the rest of it's smooth. It has an embryologic reason for this. Those are called pectinate muscles. The opening into the superior vena cava you can find easily. The valve of the inferior vena cava is a little flap. And then there's the inferior vena cava. You're not going to see, you're not going to have much inferior vena cava because the heart rests right on the diaphragm. When you cut it off the diaphragm, you're not going to have a lot of inferior vena cava hanging out the bottom. It's going to be almost flush with the heart. There's also another little opening right here. Here's the coronary sinus. It has a little flap-like valve. And it's just a leaflet. That's all it is, a thin-walled leaflet. These two valves right here. These colored circles here represent the area where you would find the SA node in yellow or the AV node in green. You will not be able to find these nodes. This is just for cartoon purposes only. The SA node is sitting at the base of the aorta. The AV node is sitting right here in the junction of the atria, or the entrance into the ventricle, I should say, through the tricuspid valve, or atrioventricular valve. The location of these is important for a whole bunch of reasons clinically. There are a lot of people with conduction disturbances, and one of the heart's cardiologists over at OU, back probably in the 80s, early 80s, developed a procedure where you could go in and electrophysiologically could pinpoint these abnormal conduction pathways, and he could use a high-frequency radio frequency device to destroy the accessory pathway and cure the conduction disturbance. So this is cardiac electrophysiologists are big deals. I mean, they're not that frequent of people, but they are very valuable in treating people with conduction abnormalities. And a lot of people have conduction abnormalities. Okay. I was at OU when the king of Saudi Arabia came over here. One of his relatives had a condition called Wolff-Parkinson-White syndrome. It's a conduction abnormality. And brought him over here for this radio ablation. And it was kind of cool, because it's like the president, not Trump, but you know, a real president, coming over to the House Science Center where they closed everything down, had a motorcade and all this kind of stuff. So, there was a student I had, a PA student, she had Wolff-Parkinson-White. And what it is when these conduction abnormalities set off, your pulse goes from 60 to 180 beats a minute. Well, if your heartbeat is that fast, you don't have time for it to fill, so cardiac output goes down, blood pressure drops, you pass out. And twice during her didactic year, you know, you're lecturing along, and all of a sudden, Allison's on the floor, passed out, you know, cold as a snapper. So anyway, she had the radio ablation surgery, and it didn't work. So anyway. There's also in the wall between the right and left atrium, there's a depressed area here. This is called the fossa ovalis. Back when you were a little bitty embryo, you still had your placenta, that used to be a hole called the foramen ovalis. Again, because you did not need blood going from the right atrium to the right ventricle to your lungs, let's just shunt it from the right atrium directly into the left atrium. And that's what the function was. As soon as you clamp the cord, the pressures inside the fetal or newborn circulation change, and that there's a flat valve over that hole. It closes because when you're a fetus, the pressure on the right side is higher than the left side. When you clamp the cord, the pressure on the left side immediately goes higher, and it clamps it and it grows shut. So your foramen ovalis becomes a fossa, or just a depression. Now, a lot of people have ASDs, atrial septal defects. And 99.99% of the time, they occur in the fossa ovalis. We'll go over that again when we get to cardiology. Now, in the ventricles here, you'll do this. Do the right ventricle. Take a window out of the right ventricle. Don't mess with the left side because it's so thick. You're not going to be able to see much. If you just want to see how thick the left ventricle is, feel free to cut into it. But really, the right ventricle is where you can see things. You can see the cusp of the Atrioventricular valves. They are attached to these parachute cord-like strings called chordae tendineae. The chordae tendineae are connected to papillary muscles. There are three. There's an anterior, posterior, and a septal papillary muscle. So they anchor, so when the atria contract, pumping blood into the ventricles, the cusp of the valves open up, right? When the ventricles contract, because the ventricles are under much higher pressure, if you didn't have something holding the cusp down, they would just invert, and the blood would go right back into the atria. Well, what happens is these chordae tendineae, these papillary muscles, contract to keep the blood from going back into the atria. If it does go back in there because of an incompetent valve, it's called regurgitation. We'll learn about that in, well, probably in about a month from now. Okay. The anterior papillary muscle is unique in that it has a a muscular bridge to the septum. That muscular bridge is called the septo-marginal trabeculae. In some hearts, it's really easy to see. There'll just be this thing about half the diameter of a pencil coming off of the septum, going into the base of the anterior papillary muscle. I'll explain the importance here in just a minute. That's called the septo-marginal band or septo-marginal trabeculae. If you look at the walls of the ventricle, out here, they're rough. The rough walls in the ventricle are called trabeculae carnae. In the atria, they're called pectinate muscles. In the ventricle, trabeculae carnae. Now, those are the atrioventricular valves, or the tricuspid, bicuspid, or mitral. The two valves with the aortic trunk and the, the pulmonary trunk and the aorta are called the aortic valve, pulmonary valves. They have three cusps. And so when these three cusps close, if they were to close, you'd be left with a space in the middle. So there's a little nodule on the end and the center of each cusp that closes off that gap. That's what the little nodule is there. Brilliant design, brilliant design. All of the valves are anchored and supported by what's called a fibrous skeleton of the heart. If it was just muscle, there would be no support for the valves. So this connective tissue, well, I guess it is dense connective tissue, separates the valves or supports the valves. And if you look at it, you kind of think of it like this. There's the fibrous skeleton. The four valves are in it like that. They're not quite in a straight line. Actually, they are in a straight line, but it's up and down, not across. But this separates, the fibrous skeleton serves two functions. One is, well, three functions. It separates the atria from the ventricles. It supports the valves, and it electrically isolates the atria from the ventricles. What's going on in the atria doesn't have anything to do with what's going on in the ventricles. Remember, from your physiology, heart muscles, you talk about the atria, all of the atrial muscle cells are connected to each other. So what happens in one of them, if you stimulate one of them, it produces a wave across the entire atria. They all contract. Same thing with the ventricle. If you stimulate one myocyte, all of them contract. Well, this isolates the atria from the ventricle. The atria can be tacking along at 300 beats a minute, and the ventricles can sit here and beat 60 times a minute because they're separated by that fibrous skeleton electrically. And that's actually what can happen in a condition called atrial flutter. If you look at an EKG, it's very characteristic. So you have what's the characteristic EKG? Back there on the back row. What's it called? Characteristic EKG of atrial flutter.
Sawtooth?
What?
Sawtooth?
Yes. So you'll have a QRS like that. You have the ventricular contractions at 60 times a minute. You have the atrial contractions at 300 times a minute. It looks like a sawtooth. Okay? All right, the intrinsic conduction pathway of the heart looks like this. You know that the SA node serves as the pacemaker. It has an there's a thing called intrinsic automaticity. If you take the SA node out and sit it in a culture dish, it'll sit there and fire 60 to 80 times a minute. This is what it does. When it contracts, or when it fires, there are pathways that send the electrical activity across the atrium, and the atria will contract from top down, squeezing blood into the ventricles. Then the impulse hits the AV node, which is on the atrial side of the fibrous skeleton. You see it there? There's the fibrous skeleton there. It's stimulated. It sends the impulse through the fibrous skeleton into a right and left bundle branch. The left bundle branch divides into an anterior and posterior hemibranch and takes the impulse all the way down to the apex of the ventricle. You don't want the contraction, you don't want the impulse to enter the ventricle up here, otherwise you're just pushing against the apex. You want the contraction to begin down there and sweep upwards, because that's where the valves are. And that's what happens. The impulse is carried down these bundle branches and released through the terminals called Purkinje fibers into the myocardium, and the impulse goes from bottom up. Now, there's right bundle branch passes through that septum marginal trabecular, or the moderator band. That's the purpose of it. I mean, that's the significance of it. You follow me? Now, all sorts of things can go wrong here. You can have blocks of these bundle branches so that the impulse doesn't distribute appropriately. Some of these blocks can be developed because of ischemic changes of your heart. Some of these blocks develop just because of congenital anomaly. I've got a right bundle branch block. It shows up on an EKG. You can see it plain as day. I've had it since I first got a first EKG when I was in PA school. I think it's okay. I mean, it hasn't changed any. I saw an EKG of myself about 2 months ago, and it looked the same as it did 40, a long time ago. It was almost 40 years ago. So, anyway.
Did you ever follow up with that nurse practitioner who was doing, listening to your heart over, well, not skin on skin, but over your shirt?
No. You know, you just had to bring that up, didn't you?
Sorry.
You had to bring that up. You know? So I've been taking my blood pressure at Good Shepherd or something. It was a little elevated, just slightly so. And so I decided I needed a physical. I had a physical about once every 5 years. You know, regardless. There's actually in the UK, they don't. If you don't have chronic disease, they do not advocate getting an annual physical. It's worthless. It's not cost efficient to do that if you don't have a chronic disease. You know, my blood. So I go to this. I call this doc right down the road to get an appointment with him, and I'll go in there and I wind up seeing this nurse practitioner who did. If you do a physical exam like she did on me, I will fail you. Hands down. That's how bad it was. It was horrible. She didn't hear anything. She didn't do it. It was ridiculous. Anyway, what did I tell you about went for the treadmill? So I told her, I went diving one time back in October, and I felt a little twinge in my chest. I was like, I need a treadmill. You know, I'm 60 years old and never had a treadmill. You know, last EKG I had was when I was 20 years old, or 22 years old in PA school. I figured I probably ought to do something. So I don't take any medicines, don't have any disease. So I go to the treadmill. I go to this cardiologist over there, back. And so the woman hooks me up to the treadmill. And I'm standing there, so she takes a baseline blood pressure. And she says, oh man, this is, hang on a minute. So she goes and comes back. She says, we can't do the treadmill. I said, why? She said, the blood pressure's too high. Well, I knew it was a little high, but how high are you talking about? She said it was something like 220 over 110, or something like that.
Yeah.
I was like, for one reason, if you had a blood pressure that was actually that high, you'd have a headache, you'd have blurred vision, you'd have things going on. I said, that's not right. She said, no, this machine's accurate. I'm going to take you over here to the cardiologist. So we walked across the hall. The hall, it was the distance from here to that trash can. I'm sitting there, and they bring one of these little blood pressure machines in, hooks it up. The blood pressure is now 160 over 105. That's not right. That's not right. You need to take it manually. Well, no, these machines are highly accurate. Well, so anyway, to make a long story short, I didn't get the treadmill. I walked out of there. But, you know, here's the point. You know, like the guy I was telling you rode the bicycle? Did I tell you about the guy who rode the bicycle? And why would you ever tell the guy not to ride the bicycle? Because you're an idiot if you tell the guy to ride the bicycle. This cardiologist came in and said, we can't do it because your blood pressure is too high. I said, take it manually. It's not correct. Because when I said my blood pressure was up a little bit, it was like 140 over 90. That's what I've been recording for the past 6 months. He said, no, these machines are highly accurate. And I said, sir, let me tell you. And he didn't know what I did. He didn't know anything about me. I said, it is physiologically impossible for your systolic pressure to drop from 220 to 160 walking across the hall. It's not correct. He wouldn't lead off, just come up with all that. You know, this is what I pray for you every night. You know, when you go out there and are a provider, and I see you 10 years from now, just don't say and do stupid things.
These machines are highly accurate.
Anyway, here's right heart failure or left heart failure. Heart failure just means your blood is not pumping. The heart's not pumping effectively, right? So you've got right heart failure and left heart failure. On the right side, because that's where the venous return is, if it's not pumping effectively the blood out of the right ventricle into the lungs, then what you have is backup of blood into the venous circulation. Here you have jugular venous distension. What vein is that? I know it's the jugular. It's the external jugular vein. Okay.
Yes.
I enjoyed that. Amanda. You're Amanda. Okay. Hang on. All right, so jugular venous distension is what that's called right there. You also have backup of blood in the veins, especially of dependent structures, dependent like gravity. And that's where you have pitting edema of the lower extremities. Pitting edema. We'll talk more about this when we talk about fluid dynamics in the hematology section. Left heart failure means that you're not pumping blood out the aorta to the rest of the body. And what happens with that, though, is the blood backs up in the lungs. So you get pulmonary congestion with left heart failure. And this is where you'll get the pleural effusions. You look at that guy right here, I mean, he's almost full.
Lung.
This is not inside the lung, this is in the pleural cavity. Okay, so involvement of the lungs because of left heart failure is called cor pulmonale. Okay? Auscultation. This is Zach. Ryan gave it up for the last lecture. Zach did this one right here. You might be able to see a little bit of the goatee. Okay. So the location of the valves, if we were to do that picture over there realistically, so the location of the valves in the fibrous skeleton is like that. But if this is a tube, and I put a valve here, and I make that valve make a sound, then the sound will transmit along the tube of water. So the best place to hear this sound, like if it clicks or if blood is flowing through it abnormally, is not right here. The best place to hear the sound is right here. So that's why the location for auscultating the valves, auscultation is to hear, auscultating the valves is right here. The aortic valve is heard best in the right second intercostal space, right beside this sternum. The aortic valve is in the left second intercostal space, right beside the sternum. And I always do this. Is it AP or PA? I always do this. I'm right-handed, so I say PA. I'm a PA. I'm a PA. So that's how I know. Backwards. I was wondering, when are you going to catch this? It's backwards. I'm a PA. That's not right. It's AP.
A and P.
Okay?
Wait, but you said aortic twice.
Okay, wait.
Yeah.
That's the way. So when I try to remember which way is which, because on the board exam you're going to be asked where's the best place to hear the aortic valve, right, or the pulmonic valve. So I always remember I'm right-handed, so I say I'm a PA, but that's not right. The correct way to do it is AP.
So you go through that whole thought process?
I go through that whole thought process. I mean, if you just remember a valve, I mean, it's a lot easier. A valve, aortic, pulmonic. However you decide to do it.
So is the aortic valve the right or the left?
Yeah, you said aortic twice.
Oh, I said, I'm sorry. The A stands for aortic. The P stands for pulmonic.
So left.
Aortic, pulmonic. It's backwards from you being a PA.
Unless you're left
Here you go.
However you decide to memorize it.
Joy told me apartment M,
Say what again?
apartment M, so APTM, APTM.
Oh, apartment M.
Oh, yeah.
Okay.
Okay. Okay, the mitral valve is the fifth intercostal space at the mid-clavicular line. And the tricuspid valve is anywhere down here at the bottom of the sternum. It doesn't really have a specific, depending on what reference you read, just anywhere down here. It's best not to auscultate over a bone. Okay? APMP. Or however Soccer wants to do it. Okay. Autonomics to the heart. Oh yeah, autonomics. Sympathetics increase the heart rate, which is called a chronotrope. Increase the force of contraction is an inotrope. If you increase the rate of heart rate and the force of contraction, you're going to increase myocardial oxygen demand. So it's not very wise to give somebody with ischemic heart disease something that's going to do either of those. Parasympathetics are going to slow the heart down. Sympathomimetics, epinephrine, dopamine, dobutamine, methamphetamines, crack. There's not much powder cocaine anymore, but that used to be the big thing. Now it's crack. Anybody worked in several people that worked in emergency rooms. You ever see anybody? You ever had a patient on a crack binge or a methamphetamine binge? Yes. They haven't been to sleep in 4 days, and they're just jacked up.
Yes.
It's pretty impressive. Energy drinks, Red Bull, Monster, keep sucking those babies down. Your age, it's Adderall's the biggie for testing, staying up. You know when we took over the student health center here 3 years ago, the nurse practitioner that worked over there, she gave everybody Xanax and Adderall. So, I mean, half the entire freaking law school 3 years ago was on Adderall for study purposes.
It seems
Crazy. We made a lot of enemies when we wouldn't refill all these things. The pseudoephedrine is another one that will jack your heart rate up a little bit. Sympatholytics, if you want to slow the heart down, then use a beta blocker. We talked about that. That's a sympatholytic, a beta blocker. Parasympathomimetic is one way to slow the heart down is to stimulate the parasympathetics, right? So parasympathomimetic. The way you can do that is to stimulate the vagus to slow the heart down. They used to do carotid massages. Remember we talked about in the neck that the 9th and 10th cranial nerves got the carotid body, carotid sinus, the aortic, the arch of the aorta. So anyway, you stimulate the vagus nerve and that will slow your heart rate down. That's called a vagal maneuver. There are other ways to stimulate the vagus because the gag reflex is vagus, right? You can give a person a tongue blade and have them gag themselves. The sensory limb is glossopharyngeal. The gag itself is pharyngeal constrictors. Remember I told you, is the vagus nerve. So if you come in with a condition called SVT, it's called supraventricular tachycardia. And I'll tell you about the physiology of that later on. But SVT, your heart rate is going 160 beats a minute. You're all lightheaded and all this kind of stuff. You want to slow the heart rate down. If it's SVT, you do vagal maneuvers. Give them a tongue blade, have them gag themselves. You can also have them hold their breath and bear down like they're having a bowel movement. That's called a Valsalva maneuver. Valsalva maneuver. That's parasympathetics that cause you to poop, right? Don't actually poop. The other is to cough. Another one is to have them close their eyes and press on their eyeballs. Press on their eyeballs. That stimulates the third nerve that's parasympathetic. Reflexively will slow the heart down. Another thing you can do is what's called a mammalian diving reflex. You take their face and you stick it in a bucket of ice water. You know that little kid, they fall through the ice up in the north, they stay underwater for an hour, they get them out, they warm them up, they're just, just like they never fell through the ice. Well, that's called a mammalian diving reflex. You can do the same thing with you. Stick your head in a bucket of ice water. You can do it on little infants. The way you do it on a little infant with SVT is you take an ice pack, like an orthopedic ice pack, put it right here on their glabella. Remember where the glabella is? And that stimulates their mammalian diving reflex. Last thing you can do is you stick your finger in somebody's butt. That's the parasympathetics cause you to poop. I just said that. Frequently little old ladies have this. They develop these pathways. You come into the ER with SVT. So I frequently stick their head in ice water and stick my finger in their butt like that. You can actually carry them around for a while. I don't do that.
Straight face.
Stop what you're doing and look at your neighbor, because your neighbor started typing that.
Yikes.